Well, I presented some new analysis of the TARGIT-A trial. The TARGIT-A trial was a randomized trial of 3,500 patients who were randomly allocated to receive a single dose targeted intraoperative radiotherapy after lumpectomy for breast cancer, compared with standard several weeks of radiation postoperatively. And this trial was started in year 2000, and the last patient was recruited in 2012. And we have published 2 papers, both in the Lancet in 2010 and 2014. And what we have found is that targeted intraoperative radiotherapy given in a risk-adapted strategy is non-inferior in terms of local control with whole breast radiotherapy given over several weeks. So it has a lot of advantage to the patient because their treatment finishes during the operation when they have their lumpectomy. Interestingly, we also found that the number of patients who died from non-breast cancer deaths was statistically significantly lower in patients who were randomized to receive target treatment compared to whole breast radiotherapy treatment. What I presented today was the hypothesis which started the trial back in 1995. And that hypothesis was this, that if you analyze mastectomy specimens, you find that in addition to the single small cancer, there are other microscopic cancers distributed all over the breast. And the principle of giving radiation to the whole breast or to do mastectomy for a patient with a small cancer is because these other cancers are present in the other parts of the breast. But what has been found in trials is that most local recurrence occurs around the tumor. So the hypothesis which started the TARGIT-A trial was that these other cancers remain dormant. Now that we have the TARGIT-A trial, we have about 800 patients in the trial, and with a total women year follow-up of 2,077, we find that we can look at local recurrences which occur around the scar of the primary tumor, which is the only area which has been radiated in these patients. So the rest of the breast, which is supposed to have these other cancers, has received no radiotherapy at all. Okay? So what we find is that the cancer area around the tumor had 7 recurrences, the other breast had 6 recurrences, and the remaining breast had only 2 recurrences. If 2/3 of these patients have other cancers and 80% of them in other quadrants, that is 60% of 80% is about 50% of patients should have had cancers in other parts. That is, out of 800, 400 should have had other tiny cancers which were not treated, but they haven't grown. Only 2 grew into new tumors. So it just shows that it is not necessary to give whole breast radiotherapy to the other parts of the breast. In the randomized data, when you analyze it that way, you find that patients who were randomized to receive target had 2 recurrences out of 1,100 patients in the other quadrants. In the patients who received whole breast radiotherapy, they had the breast treated, but despite that, there were 2 recurrences in 1,100 patients. So giving whole breast radiotherapy did not reduce the occurrence of cancer in other parts of the breast. So this sort of proves the hypothesis, gives good support to the hypothesis that these are not affected by giving whole breast radiotherapy, and gives support to the idea that giving targeted intraoperative radiotherapy to the area immediately around the tumor during lumpectomy is a safe alternative for patients, of selected patients of breast cancer. What we want to say is these patients should be selected for this using the TARGIT-A trial selection criteria. So they should be 45 years or older and with tumors which are less than 3.5 centimeters in size and preferably hormone receptor positive tumors. Those who do not fit this criteria would be suitable for the new TARGIT-B trial. Now new means it has already started. 20 centers are participating in the TARGIT-BOOST trial. Now TARGIT-BOOST trial is based on the hypothesis that giving targeted intraoperative radiotherapy during surgery as a boost in addition to whole breast is superior to external beam radiotherapy boost given afterwards. So patients such as younger than 45 or over 45 with high risk are now randomly allocated to receive target boost during surgery or no target boost during surgery. And then everybody has whole breast radiotherapy, and patients in the control arm have got external beam boost. And we want to randomize 1,700 patients to see if this target boost is superior to the whole breast radiotherapy boost. And this is based on the initial data of 300 patients in whom we found the recurrence rate was only 1.7%. So it is much lower than expected. So that's why we want to start the trial. Trial is funded by the Department of Health in the UK, And we already have 20 centers randomizing in the trial. So if anybody's interested, please ask us at the clinical trials group in University College London.